Hi, everybody. My name is Johanna. I am Assistant Director of Clinical Services, and just want to say, yeah, welcome. Thank you for joining us. Today, we're going to be discussing burn care and management with a presentation by our wonderful Dr. Yaffe. Just a quick note before we get started. Please write any questions that you do have in the chat, and then these can be addressed in the end. And then, in order to get credit for the continuing education hours, just make sure to respond to all the polling questions. So, without further ado, Dr. Yaffe, take it away.
Thank you, Joanna. Hello, everybody. My name is Nazat El Yafi. I'm a wound care physician with ProHealth One. Thank you for joining this webinar that is titled Burn Care and Management. Just a quick disclaimer. This presentation is for educational purposes, and I have no disclosures. All right, let's jump into it. So the objectives of this presentation is threefold. I'll start first by giving a quick historical evolution of burn care along with some current statistics. And then I'll be talking about different types of burn injuries and how to assess them and evaluate them. And then lastly, we'll be talking about evidence-based treatment and management strategies. So we'll start first with some facts. In 2021, around 400,000 fire or burn-related injuries occurred, along with 250,000 injuries related to contact burns. Unfortunately, we had 3,800 deaths related to inhalational injuries. There are more than 29,000 burn admissions per year. Here's some demographics of the patients who are admitted to burn centers across the US. A third of the patients are female, 57% were white, 19% Black, 14% Hispanic, 2% Asian, and less than 1% Native American. So the people at risk are usually the people who are at the extremes of age, children and the elderly, and also the disabled and military personnel. All right, we'll go into some historical fun facts. So the oldest known documentation of burn treatment was in ancient Egypt around 1500 BC. They came up with a couple of innovative ideas. I don't know how, but they did. And yeah, so they used a mixture of cattle dung, beeswax, ram's horn, barley porridge soaked in resin. Another creative idea was warming a frog in oil, then rubbing it on the burned area. And then around 400 BC, the famous philosopher and physician Hippocrates was concerned with the cosmesis of burn wounds, and he recommended using pig lard, squill, which is basically a lily plant, and olive oil to make the scars neat. It was also documented that he used vinegar, red wine, and bitumen mixed with resin. Bitumen is basically asphalt. And then in the first century AD, there was a Greek physician in the Roman army named Pedanius. He recommended using honey for ulcers. And then in the Middle Ages, we have a French military surgeon, Ambroise Paré. In the 1500s, he was the first to describe early burn wound excision. And then a little bit later, in the early 1600s, we had a German surgeon, Fabry, who described the debridement of burn eschars to allow drainage of fluids and better penetration of treatments. And then in the 1800s, we have another French military surgeon who came up with a classification for burn depth. And then after him, a Swiss surgeon realized the importance of estimating the burn surface area. And in 1869, he was the first to perform a free skin graft. All right, question number one. This is a polling question. What is your level of experience managing burn injuries? Extensive experience, occasional experience, rarely encounter burn cases, no experience. We'll give you a minute to pick your answer. All right, so all of you rarely encounter burn cases. All right, let's do it then. And then lastly, the 20th century, we have a pioneer who was a Slovenian surgeon, Dr. Zora Janzekovic. She was the first to pioneer the tangential excision of burn wounds in early autografting. Tangential excision basically means we peel off thin layers of dead necrotic tissue parallel to the surface of the body until you reach healthy tissue that is bleeding, because this will help with wound healing. So types of burns, the most common one we have is thermal, we have chemical, electrical, sunburn, abrasions, and radiations. Thermal burns can be caused by fires, scalds, contact with hot surfaces. Scald burns occur from liquid immersion or from splashing or spilling liquids. And this is the most common type of burn in the pediatric population. We have to be careful with liquids because at 150 degrees, it can give you a full thickness burn within a couple of seconds. Then we have chemical burns, and these include acidic, alkali, organic compounds by either contact, inhalation, or ingestion. And these materials are found pretty commonly in our daily lives, such as oven and drain cleansers, fertilizers, industrial cleaners, bathroom cleaners, fuel and gasoline. Acidic burns give the appearance of leathery eschar caused by tissue damage by coagulation necrosis. And then we have alkali burns. They can cause even more extensive damage than the acidic burns by liquefaction necrosis, which basically the necrotic tissue turns into a liquefied mass of dead tissue. Organic compounds can give you systemic toxicity. Electrical burns can be caused by frayed cords, electrical outlets, lightning, high voltage power lines. And with these types of burns, we need to be very careful because we can only see the entry and exit points. But very often we would have significant damage in underlying tissue that is not visible to us. Then we have radiation injuries. These are caused by exposure to electromagnetic particles, such as X-rays or atomic bombs. So please stay away from atomic bombs. And then we have sunburns. This is usually caused by ultraviolet B rays. And then we have abrasions and frictions. These are caused by rubbing against hard surfaces. And friction, it can be classified as a heat burn because with friction, you generate heat that leads to the injury. This is an example of friction injury. All right, now do the classification of burn wounds. So we start first with the first degree superficial burn injury, which is basically the most superficial injury that involves only the epidermis. Then we have second degree burn injuries, and this is divided into two sections also, superficial and deep injuries. Superficial involves the epidermis and the outer layer of the dermis. The deep second degree involves the deeper layers of the dermis. And third degree injuries are basically, they involve the entire layers of the skin, all layers of the skin. All right, question number 2. Which aspect of burn care would be most valuable to your nursing practice? Early identification and assessment of burns, wound care and dressing techniques, pain management for burn patients, preventing burn in high-risk residents, coordinating with outside providers. I'll give you a minute. All right, so almost half of you are interested in wound care and dressing techniques. and almost a third of you, early identification and assessment of burns. All right, let's continue. So the degrees of burn injuries. So we'll start with the first degree appearance. It's usually red, pink, erythema, dry surface, no blistering. Usually you don't see any edema or scarring. And it's very tender to touch. A very common cause is sunburns. Second degree burns, this is the superficial second degree. You will see some blistering, some mottled skin. It's usually blanchable. You might see some edema and usually no to minimal scarring. And usually the causes include contact with hot liquids or flash burns. And it's also very tender to touch. Deep second degree burn injuries. You also have blisters, mostly ruptured. Red or pale in color. They're also blanchable, but you will have more edema. And most likely a scar will result at the end. And these are also painful. Third degree burn injuries, they appear dry, leathery eschar. They can have different colors, either white, black, or red. These are non-blanchable, no capillary refill, and you'll have much more significant edema and scarring. And usually these types of injuries are insensate because the nerve endings are burned and destroyed, so the patient loses sensation in that area. Common causes include fire, electricity, lightning, prolonged exposure to hot objects and liquids. And then we forgot to mention the fourth degree burn, which is very uncommon. Basically affects the entire layers of the skin, plus it can extend into the fascia, muscles, tendons, and bones. Same thing with the third degree. Patient loses sensation because all the nerve endings are destroyed. All right, now to burn treatment and management. So there are a couple pathways you need to determine before when you evaluate the burn patient. So it's either a non-complex injury or complex injuries. Non-complex injuries, we need to initiate first aid. For complex burn injuries, we need advanced burn light support. Like any other trauma situation or shock situation, needs to start with the ABCDEs, airway, breathing, circulation, disability, exposure, and evaluation. Once that's done, then we go into estimating the extent of the burn areas using the rule of nines, which I'll talk about a bit later. So first aid includes you need to stop the burning process. And if the victim has burning clothes, this needs to be removed immediately. If a limited area is injured, then you can immerse it in cool, tepid water for within 20 minutes of the injury for half an hour. This would help with improving the pain and edema and tissue damage. You can use wet towels or hydrogel. As for chemical burns, they require longer irrigation. And also, I'd like to caution people when chemical burns, and I've seen this happen before. So say someone got an alkali burn injury, and then they think maybe we can balance it out with adding an acidic material to balance the pH out. Please don't do this because this can cause even more damage. It's not a good idea. For electrical injuries, we do not irrigate. As for large areas, basically you need to cover the patient because with losing a large area of skin, you're losing the barrier. Patients can lose heat and get hypothermic pretty quickly. And it's important to have their pain controlled. Here we have some criteria for admissions into burn units. Most of the burn units, they have pretty similar criteria for the most part. So they might have minor differences between one place and another. But the major criteria is basically partial thickness burns, than 10% of the total body surface area. Injuries involving the genitals, face, major joints, hands and feet, any third degree burn, electrical, chemical, or inhalational burns. Where I was trained, one of our criteria was we admitted snake bites. Not sure why, but we did. All right. How do we assess burn injuries? So we need to estimate the surface area. We need to know the depth of the burn injury. And then we need to also take in mind the general condition of the patient. Do they have comorbidities? Do they have any traumatic injuries, inhalational injuries, or circumferential burns? So how do we estimate the surface area? So the most common scale used is the rule of nines. This basically divides the body into anatomical regions that represent 9% of the total body surface area. So for example, the entire head is 9%. Each upper extremity is 9% on both sides, anterior and posterior. For the lower limbs, each side is 9%. So anterior, it's 9% for the leg, posterior, it's 9%. And for the palms and fingers, it's considered 1%. And a lot of people use their palms to help them estimate the surface area. And then the more surface area that is injured, the higher risk of morbidity and mortality. But we need to keep in mind a few things with the rule of nines. It's not used for pediatric population. They have their own modified version. With obese patients, also it can be inaccurate because they have this proportionally larger trunks. And so these can result in, sometimes also you can have human error, you can underestimate. All right, talking about now, we have local and systemic responses to burn injuries. The local injuries, the responses usually starts with inflammation and then regeneration and then repair. And each wound is divided into three zones. The first zone is called the zone of coagulation or necrosis, which is in the center of the wound. This is where you have irreversible tissue damage and no blood is reaching it. The second zone, which is right around the first zone, is called the zone of stasis. You'll be able to have some recovery with tissue. You'll have some perfusion, but it's decreased. And then the most outer zone is the zone of hyperemia, where you have a good amount of perfusion going there and a good chance of tissue recovery. Systemic responses usually happen with like more than 10 or 20% of TBSA. And these responses happen because of release of inflammatory mediators, which include so that's why patients can go into shock. They can have hypotension, bronchoconstriction, increased metabolic rate, and reduced immune response. So what are the risks of burn injuries? Because of the loss of the skin barrier, it's easy for pathogens to invade and cause infections. Also, because of the loss of the barrier, you can have insensible fluid loss, and you can have also heat loss, so you can go into dehydration and hypothermia. All burn patients need to be immunized for tetanus and have also loss of function depending on the location of the injury. For burn management, so quick guideline. So we need to clean the wound first, debride it, remove the necrotic and dead tissue. Splinting and positioning is important, which I'll talk about a bit later. Then topical antibiotics and treatment of burn wounds. So, like we said, it's very important to clean the site of the injury first. We need to have a clean wound bed to prevent infection and promote wound healing. Debridement also is basically just excising all the necrotic and damaged tissue. We have a couple of techniques that we can use sometimes. Escherotomies are basically removing eschar to relieve pressure. So sometimes people can have circumferential burns around the limb, for example, and this can compromise the circulation to that limb. So it's really important to, in a timely manner, to release that eschar to restore perfusion. Also, it can happen if someone has a circumferential burn to the chest. That can affect breathing and respirations. So that's also very important to perform escherotomies. And we have hydrotherapy, is basically using water to clean and debride wounds. Splinting and positioning. This is very important, especially depending on the location of the injury. But generally, this helps with reduction of edema, increasing range of motion, promoting wound healing, tissue elongation to avoid deformity. Because when you develop scars, you can, if it's not splinted and positioned properly, it can have, a lifelong deformity, which would be much more difficult to fix later. And it helps with remodeling the joints and tendons. For hypertrophic scarring, we can use pressure garments to prevent scar formation. As for the antibiotics and burn injuries, generally oral and IV antibiotics are not used unless it's indicated, but generally we don't use oral or IV antibiotics, and it can cause skin damage. But what we use a lot is topical antibiotics. This would help with, clearing the pathogen burden, the surrounding tissue in the wound bed, and allowing proper healing when graft is applied. So topical antibiotics have a higher chance of success along with surgical debridement and cleaning. All right, question number 3. Which topic are you most interested in learning more about during this webinar? Initial burn assessment and triage, fluid resuscitation and wound care, pain management strategies, burn complications and infection control, long-term rehab and recovery. I'll give you a minute. All right. Most of you want burn complications and infection control. All right, let's do it. Topical burn treatments. So here I'll be talking about some products that we use commonly in burn injuries as for topical treatments. So we have sulfamyalon, which is a carbonic anhydrase inhibitor. It's a broad spectrum. It covers both gram-positive and gram-negative organisms, including Pseudomonas. It can penetrate into cartilage and eschar. So consider when using it when there's minimal vascular supply or suspected infection. Silvadene is pretty similar to the previous one. It also covers gram-negative and gram-positive bacteria, including Pseudomonas. It's very expensive, and the dressing must be changed daily. I need to, make sure that because sometimes it can cause pseudo-eschar, which is basically the ointment is building up. It can resemble a burn eschar, and it would make it difficult to differentiate between the cream itself and the burn wounds. So when the dressing is changed, it needs to be cleaned thoroughly. Civerlin, which is a non-adherent antimicrobial dressing, usually used for minor burns, and has antibacterial properties that is effective for up to 7 days. Other topical burn treatments that we have, bacitracin and neosporin. It's a very commonly used ointment. It helps moisturize, very useful for painful and perineal and facial burns. It also covers gram-negative and gram-positive organisms. Zeroform is also commonly used. It contains bismuth and petroleum jelly impregnated gauze. We have Acticoat, which is an antibacterial silver dressing, which can reduce scar formation. We have Mepitel and Mepilex. These are synthetic dressings. These can absorb if the burn wound is putting out a huge amount of fluids. These can help absorb the extra fluids and help reduce the pain and improve healing. Remember, always to use aseptic, non-touch techniques. All right, now to radiation burns. So ionizing radiation is used to inhibit the growth of cancer cells, basically. But radiation therapy, unfortunately, does not only attack cancerous cells, but it also attacks healthy cells around the cancer cells. So radiation can make the skin very vulnerable. What we need to keep in mind with radiation injuries is that usually the manifestations are a little bit delayed. Usually you would start seeing the symptoms around 2 to 3 weeks after exposure to radiation. And you would see usually erythema, redness, macular rashes. This is all because of capillary dilations and increased vascular permeability with increasing edema. We have dry desquamation. The skin appears red, itchy, flaky, and dry. And we have moist desquamation, which is blister formation, peeling, and sloughing. And then we have even a more delayed reaction. And this usually occurs months to years after. And you'll basically see a translucent skin. You won't see any hair follicles or sebaceous glands or sweat glands. You'll see those spider veins, telangiectasias. You will have elastic fiber damage, necrosis, and ulceration. And then because of the necrosis and ulceration, there's a higher risk of infection. There's also something called radiation recall. It's basically an acute reaction where the chemotherapy agent is used after radiotherapy. And this is when chemotherapy is usually used within the first 2 months after exposure to radiation therapy. And if that occurs, usually the treatment is you stop the chemotherapy until the dermatitis resolves. Some treatment guidelines. So it's very recommended to use mild non-alkaline soap with lukewarm water. Avoid products that have irritants like perfumes or alcohol. Use petroleum-based products and mild non-medicated shampoos. To help prevent radiation skin reactions, use hydrophilic lotions and creams such as Aquaphor. Apply gently and do not rub. Aloe vera can be used to soothe the skin, but it's not a moisturizer. You can use normal saline compresses and soaks. Avoid any hot or cold exposures. Wear comfortable and loose-fitting clothing. So the long-term effects that poorly affect the wound healing outcomes, you would have atrophy of the epidermis and its structures, atrophy to the microvascular occlusions and connective tissue. Fibroblast production is decreased and cellular damage is significant. Some other management strategies that we use. So pain control is very important. You can use, opioids, non-opioids, topicals, and we have non-pharmacological methods also that we can use, and I'll talk about that a bit more later, such as CBT, relaxation techniques. And then it's very common for burn patients to complain of itching. So the way we can manage these are moisturizers, antihistamines, pressure garments, avoid heat and physical activity. Some portion of the patients will, once their burn wounds heal, they would develop either hypertrophic or scarring or keloids. And the way to manage those are, you can massage those scars, moisturize them, pressure garments, silicone sheets, and physiotherapy. Nutrition is very important, especially with extensive burn injuries, because they're in a hypermetabolic state. They can lose weight, they can lose their muscle mass, their immune function tanks. So it's very important to provide them with high energy a diet that contains protein, carbohydrates, and we usually provide them with a bunch of supplements such as amino acids like glutamine and arginine, a bunch of vitamins such as A, C, D, zinc, iron. Carbohydrates is important because it has a protein sparing effect. So, and if the patients are malnourished, their wound healing would not be optimal, and they're at risk of infection, graft failure, and other complications. So we also have fluid resuscitation. That's important. Because of the loss of the skin barrier, you have insensible fluid loss, and you have also vascular permeability. So it's important to keep them hydrated. And then nutrition, if the patient is not able to eat enough, we can have an NG tube placed because enteral feeding is always better than parenteral feeding. Some patients might need like 6,000 calories a day.
Mm-hmm.
And then going into the psychological issues, a lot of the patients, especially with extensive injuries, they might develop PTSD, depression, anxiety, distress, flashback of the incident that they had. They look negatively to themselves because of their body image. So counseling and psychological support is very important there because there's a higher suicide risk also with these patients, unfortunately. PTOT is also important. They need to regain their strength, they rebuild their muscle mass again, improve their range of motion, and they need to learn how to use ADLs. And I think that's it. We have a couple of webinars coming up in October. Topic is about palliative wound management, and in November, pressure injury prevention. This is our contact information and our references. Any questions?
All right, yeah, let's check chat, see what we have here. So I did have a question for you. If a blister ruptures on its own, what would be the best immediate wound care approach to minimize contamination of that?
So blisters, there's different school of thoughts regarding blistering. And if it ruptures on its own, you can apply something like bacitracin, neosporin, covered with Zeroform, and then wrap it depending on the location, or cover it with the gauze. If the blister is not ruptured, some people suggest just leaving the blister alone because it's considered like a biological dressing. So that can be left alone. Some people recommend deroofing the blister. But if it popped, yeah, generally covered with some topical antibacterial with along with like a petroleum jelly.
Okay, awesome. And then what else we have here? Um, is a healed burned area always compromised like a healed pressure ulcer would be?
Uh, Pretty much, yeah, because when the healing process is completed, the tissue doesn't go back 100% like it was before. Similar to pressure injuries, it's always like 80 to 90% back to normal. So, yes, it's not unfortunately 100% back to normal, correct?
Okay, let's see if there's anything else here. And then why is it worse for elderly patients to get a burn?
Because basically their physiology, their tolerance, and because usually they have more comorbidities than the younger population, that would put them at a higher risk of having complications, morbidity, and mortality.
All right, awesome. See if there's any other questions I'm seeing here. Taylor, would you have any questions for Dr. Yaffe? Oh, let's see. I have another one here. What do you think of copper dressings?
Proper dressings. Um, I haven't personally used them before. I'm not sure. I haven't seen like where I was trained or practiced. I'm not sure, to be honest.
I actually haven't either.
Yeah.
All right. Well, thank you, everybody. Just to yeah, keep you updated, we are always doing monthly webinar series right now. It's going to be the first Wednesday of the month. We also do provide in-services to the facilities. If there's a specific topic, one of the nurses could come out and do some education. You could go to our website and sign up there for something that you might be interested in.